Okay, today I am going to discuss about benign bone tumors. So this portion of orthopedics is cold orthopedics. It's in the cold orthopedics, and it is the one of the most important topics, especially the benign bone tumors. Some of the tumors like giant cell tumor, osteosarcoma, and uh, giant cell tumor, Ewing sarcoma, osteosarcoma are one of the most widely discussed topic and frequently asked questions in the examination. So I'm today discussing about this lecture. In this lecture, I'll be discussing about benign bone tumors as well as the classification of benign bone tumors. And in the next lecture, I'll also be discussing about the remaining topics in the benign bone tumors. Bone tumors may be defined as a new growth arising in the bone or derived from cells which are components of the skeletal tissue. Right? Bone tumors, it's the tumor arises from the bone cells. Okay, there's nothing new. Pathology tumor. The characters of benign bone tumor are the characteristic of bone tumors in comparison to the benign, it is encapsulated. Capsulated भएको हुन्छ त्यही कारणले गर्दाखेरि एक्सपेन्सन हुन पाउँदैन एउटा लेभलसम्म एक्सपेन्सन हुन्छ benign bone tumor, whereas malignant bone tumor it's permeated type, it infiltrates the capsule and it metastatizes. यही कुरा देखाएको छ पिक्चरमा. So generally talking about the radiographic features of the benign bone tumor in comparison to the malignant tumor, key difference. So what is the main difference? When you see a radiograph and you suspect a tumor, and you can make preliminary diagnosis that it's a benign or it's a malignant by seeing the radiographic features, and it's the very important aspect of the tumor section of the bone. So benign bone tumors, they are well defined and it has sclerotic borders, and sclerotic, whereas in case of malignant bone tumor, it's both eaten or permeative type, sclerotic border also. Sclerotic borders there's a wide zone of transitions. Sclerotic defined malignant bone tumor there is wide zone of transition. Benign bone tumor has solid periosteal reaction, whereas malignant has interrupted periosteal reaction. Okay, interrupted periosteal reaction ma अब विभिन्न फर्म हुन्छ जस्तै sonray appearance, Coleman triangle हरु डेभलप भएको हुन्छ भने in case of benign bone tumor there is solid periosteal reaction, and the benign bone tumors has geographical bone destruction, whereas in case of malignant bone tumors there is moth eaten or permeative type of bone destruction. Geographical bone destruction एकदम डिफाइन हुन्छ हैन. मोथ इटन भनेको चाहिँ एकदमै भेग टाइपको चाहिँ त्यसको जुन एजेसहरु हुन्छ त्यस्तो भेग टाइपको हुन्छ है. अनि there is the involvement of soft tissues. Soft tissues are involved in case of malignant bone tumor, whereas there is no soft tissue mass, okay, around the benign bone tumors. This is a very important differential, radiographic differential of benign tumors, where in compared to malignant lesions. So coming to the classification given by WHO, it has been revised and it's broadly classified. Benign bone tumor is broadly classified into bone forming, cartilage forming, and fibrous tissue, giant cell tumor, vascular tissues, and other connective tissues and non-tumors. So in case of bone forming benign bone tumors, it's osteoma, osteoid osteoma, osteoblastoma. In case of cartilage forming, there's chondroma, osteochondroma, chondroblastoma, chondromixed fibroma. In case of some of the examples of fibrous tissue or benign tumors are fibroma, fibromatosis, and in case of giant cell tumors are also called as osteoblastoma. It's benign osteoblastoma. Benign osteoblastoma malignant type. It has got the malignant variant also. Vascular tissue, benign vascular tissues tumors are hemangioma, hemangiopericytoma, hemangioendothelioma, and other connective tissues like fibroma, histiocytoma, lipoma, and other tumors, neurofibroma and neurolimoma. This is one of the important classification. Anakin staging system for benign tumor. Anakin has a staging system for both malignant and benign tumor of the bone. So today we are discussing about one is the benign part. It is broadly classified into latent, active, and aggressive type. Latent is it has well demarcated borders, and it goes very slowly and stops. Sometimes it heals spontaneously, and there is a negligible recurrence after intracapsular resection. In case of active benign bone tumors, there is well-defined borders, but it may show vertical thinning, like in case of aneurysm bone cyst. Growth is limited by natural barriers like compartment. Compartment fascia or bone can behave like compartment. Any fascia, fascia system हुन्छ हाम्रो शरीरमा. There's fascia or any bone can act as a compartment. There is negligible recurrence after marginal resection. In case of aggressive benign tumors, it has got indistinct borders. Growth is not limited by natural barriers like in case of giant cell tumors, and 5% may have pulmonary, special metastasis to the pulmonary part. High recurrence after intercapsular or marginal resection. So therefore, wide resection is preferred method for the treatment. Coming to the osteoid osteoma. Osteoid osteoma is the most common true benign bone tumors. The most common true benign bone tumors in the body is osteoid osteoma, and it comprises of the 10% of the benign bone tumors. It mainly occurs in second to third decade of life. There is male predominance in osteoid osteoma, and the lesions are usually small as compared to osteoblastoma, and it's less than 1.5 centimeter, and it has predilection for lower extremities like femur, tibia, and malignant changes are not documented. Some of the osteoid osteoma may regress spontaneously. It has clinical features like persistent pain, especially it aggravates at nights, and it's relieved by NSAIDs. NSAIDs. So some of the various theories have been postulated why this osteoid osteoma causes pain at night, and it's relieved by aspirin. It is still under research, and it's a matter of debate. But some of the documents, some of the journal has cited that osteoid osteoma, in case of osteoid osteoma, there is the production of the prostaglandin E. Prostaglandin E is production of prostaglandin E is mediated by cyclooxygenase 2. So NSAIDs like aspirin, they inhibit cyclooxygenase 2, and thus causes the relief in the pain, especially at night. Okay, and when the lesion is near the joint, it causes swelling, stiffness, and the contraction of the joint. And when there is a lesion in the vertebra, it causes the scoliosis. The diagnostic modalities are X-ray, CT, MRI, technetium, and these are the various diagnostic modalities. The lesion can be identified in the X-ray also, and it has a central radiolucent nidus with surrounding bony sclerosis. CT is the best to identify nidus. Right? CT is the best in case of any bony pathology. CT is the best imaging modality. Technetium bone scan has increased, shows increased uptake by the nidus and the body tumor, body growth. So there is increased uptake. Any tumors in case of bone scan shows increased uptake, or in case of infection, technetium bone scan increased uptake. MRI has limited role. Soft tissue change and surrounding edema are well appreciated in MRI. Especially soft tissue tumor MRI body important also. Bone lesion CT body important also. So this is in the diaphysis, in the distal third of the tibia. In the diaphysis, there is a radiolucent nidus, and it's surrounded by sclerotic bone. Okay. Medical treatment. Are medical treatment, percutaneous radiofrequency ablation, and open surgical procedures. Okay, medical treatment consists of the aspirin. Okay, NSAIDs. If patient is willing and asymptomatic and symptoms adequately is controlled, then we can treat the patient on the NSAIDs. Okay, NSAIDs. The lesion may spontaneously heal after 3 to 4 years. So sometimes it may be cumbersome to the patient, but sometimes they can select this mode of treatment. It's not so much preferred method of treatment. Percutaneous radiofrequency ablation भनेको रेडियो फ्रिक्वेन्सीले दाब्ने भन्छ कि त्यस्तो लिजनमा गएर एउटा सानो इलेक्ट्रोड छिराएर त्यसपछि त्यहाँ चाहिँ टेम्परेचर हाई गरेपछि त्यो एरियाको चाहिँ त्यो एराउन्डको चाहिँ बोन ट्युमरहरु चाहिँ they will be dead. Okay, and that was the relapse of the symptoms. Okay, the percutaneous radiofrequency ablation for lesions of pelvis and long bone unreachable sites, especially in case of unreachable sites like in pelvis, and in some cases in long bones also this method can be tried. First, the CT guided needle bone biopsy is done, and through which the radiofrequency electrode is inserted through the cannula of the biopsy needle. The temperature of the tip is maintained at 90 degrees for 6 minutes, and it's done in outpatient basis, and there is a low chance of recurrence, which is less than 10%, and it is not indicated in vertebral lesions and small bone of hand and feet, which can cause thermal injury in the small bone of hand and feet, and thermal injury to the spine in case of the vertebral lesion. So it is not preferred in hand and vertebral. Surgical methods are curettage and in-block resections. Curettage is mostly preferred. In-block resection is not so much preferred because it may cause post-operative fractures. Sometimes Burr-down technique can also be used. The sclerotic bone is Burr-down and the nidus is curetted. Nidus is removed using the curate, and it has a recurrence of less than 10%. Coming to osteoblastoma, it's also known as giant cell osteoid osteoma. Okay, it's known as giant cell osteoid osteoma, but it's larger than 1.5 centimeters. It comprises of the 3% of the all benign bone tumors and occurs into the in first to second decade of life. The male to female ratio is 2:1. Spine is the most common location, and it also has the predilection for metaphysis or diaphysis of long bones, small bones of hands and feet. The clinical features are pain, but it has no night pain. Okay, it has no night pain, and it's not related by NSAIDs. Diagnosis is X-ray, CT scan, MRI. Okay, X-ray is well demarcated osteolytic lesion is seen, may contain flakes of ossifications in case of osteoblastoma, and there is surrounding sclerosis. Okay, the surrounding sclerosis is thin because it's a little bit more aggressive type. Right? It's a little bit more aggressive. If the sclerosis is thick, then it's benign, more benign, and if the sclerosis the thinner the zone of the sclerosis, the more the tumor is aggressive. Okay, this is understanding. जति थिक छ त्यसको चाहिँ sclerotic zone त्यो चाहिँ benign हो, जति thin छ त्यो त्यति नै aggressive type of tumor हो. CT scan is the investigation of choice in case of any bone tumor of the in case of any bone tumor or any tumors in the bone. A radioactive scan is in this optic सबैमा त्यही नै हुन्छ. MRI soft tissue and interspinal if there is thin sclerosis, so it may have chance of soft tissue involvement. So in case of soft tissue involvement, MRI is the investigation of the choice, and if there is interspinal extension also, MRI produces a good quality of image. This osteoblastoma, this part. Treatment is excision and bone grafting. Local recurrence is common. Malignant transformation has been reported in few journals. Chondroma. Chondroma is benign lesion of the hyaline cartilage. It's a common cartilaginous tumor, and it affects all age groups. Any bone can be involved, but mainly affects the phalanges of the hands and feet, and usually it's asymptomatic and discovered incidentally or after the pathological fractures. Enchondromas, there is a term enchondromas, which means that the chondroma that arises within the medullary cavity, and periosteal or juxtacortical chondromas has also been reported, which arises on the surface of the bone. Periosteal and periosteum by juxtacortical near the cortex. These are the real type of chondromas. Okay, this is the chondroma. Okay. There is a term called multiple enchondromatosis. Multiple enchondromatosis is also known as the Olier's disease. Okay, eponyms are shown as Olier's disease. Multiple enchondromatosis is also called as Olier's disease. Okay, it's a rare variant of enchondromatosis, and there are multiple enchondromas, and many cartilage tumors appears in the large and small tubular bones and in flat bones, especially in the hands. Hands body is multiple enchondromas. This is the enchondroma within the medullary cavity, and this is the enchondroma. Okay, and this is also enchondroma. Maffucci syndrome. Also, your eponyms are multiple enchondromatosis associated with soft tissue hemangiomas is also known as Maffucci syndrome. The individual lesions of multiple enchondromatosis are similar to solitary enchondromas, but they have the tendency to become malignant tumors. Okay, 25% of the patients with Olier's disease are diagnosed with sarcomas by age 40. Okay. The diagnosis is by X-ray, and it looks benign appearing tumors, and in X-ray it is seen as a translucent lesion, and sometimes stipple calcification, punctual calcification, or Paupen type of calcification are seen within the lesion, and it is mostly associated in the small bone of hands and feet. Sometimes there is the erosion and expansion of the sometimes there is the erosion of the cortex and there is the expansion of the overlying cortex. Cortex you फुकेको जस्तो देखिन्छ के हेर्दाखेरि एक्सपेन्सन हेरेर यसमा फुकेको छ. This is normal. This enchondromas, there is erosion of the cortical erosion छ. यसमा हेर cortical bridge नै भएको छ हैन. There is the cortical bridge and there is the erosion. This okay. The cortex is expanded. In long bones, especially in long bones, deep industrial erosion greater than 2 1/3 of the thickness of cortex indicates a chondrosarcoma. Sometimes if the tumor is associated with soft tissue mass, then it's the enchondromas has turned into a malignant tumor. The benign tumor has turned into the malignant tumor. Enchondroma ko malignant version bhayeko chondrosarcoma. This is the chondrosarcoma. So histologically, the tumor consists of mature hyaline cartilage proximally located enchondromas. Are hypocellular, and if it is cellularity or atypia, then it indicates chondrosarcoma. But in case of hands and juxtacortical cortical chondromas and multiple enchondromatosis may be relatively hypercellular. Pure hypercellular bhaye pani there may be mild atypia and still be considered as benign tumors. Proximally as located छ कि distally भनेको ह्यान्डमा जस्ट ह्यान्डतिर हैन जुन चाहिँ centrally located छ कि यदि if it is located in the peripherally in the hand. In case of centrally located, if it is associated hypercellularity or atypia, then it indicates the malignant change. But in case of hands, though they may be relatively hypercellular and there is mild atypia, they may still be considered as benign tumor. The treatment of solitary enchondromas are no further intervention is required unless and until we suspect a malignant change. Okay. Multiple enchondromatosis. In case of multiple enchondromatosis, the treatment is difficult. The lesions are not treated individually, but if there is any deformity or deformity, or it hampers the function of the limb, then various osteotomies can be done, or it may be curated, and the enchondromas are monitored for any malignant changes in the futures. Osteochondroma. This is the most common benign tumor of the bone in the body. Okay, the most common true benign tumor of the bone in the body is osteoid osteoma. But this is the most common benign tumor of the bone. What is the most common benign tumor of the bone? And the most common benign tumor of the bone is osteochondroma, whereas the most common true benign tumor of the bone is osteoid osteoma. You also did count versus it's a developmental malformation. त्यही भएर यसलाई ट्रू भन्दैन के बुझ्यो नि है developmental malformation rather than the true neoplasm. So it's not true benign bone tumor. Most common benign bone tumor is osteochondroma. यदि true neoplasm भनेर क्वेशन सोध्दैछ भने that's osteoid osteoma. It's originated within the periosteum as well as small cartilaginous nodules. It is produced by a progressive endochondral ossification of a growing cartilaginous cap. And it's like endochondral ossification. There is two types of ossification. There is membranous ossification and endochondral ossification. And long bones are especially produced by endochondral ossification. There is endochondral ossification helps in lengthwise increasement of the bone. Whereas membranous ossification helps in white को कुनै पनि बोनको white increase हुनलाई membranous ossification चाहिन्छ भने कुनै पनि बोनको चाहिँ length increase हुनलाई चाहिँ यो endochondral ossification, especially in long bones, endochondral ossification is the main. The growth of the lesions parallels that of the patient and stops once the skeletal maturity is reached. So it's not a true tumor. Right? जब some patient बढ्छ 3 yearsसम्म बढ्छ त्यसपछि जब patient बढ्न छाड्छ हैन once the patient becomes mature then it stops. Most lesions are found during the period of rapid skeletal. Single lesions are found in 90% of the cases. In 10% of the cases may be associated with multiple lesions. Site may involve any bones formed in cartilage, usually found on the metaphysis of the long bone. Especially पहिले चाहिँ फाइसिसबाट स्किन ग्रोथ हुँदै जान्छ, पछि चाहिँ ग्रोथ हुँदै गएपछि चाहिँ यो मेटाफाइसिसमा आएर एन्ड हुन्छ. Okay, near the physis, especially in the distal femur, proximal tibia, and proximal humerus. Osteochondromas are of two types. They may be pedunculated or sessile, and malignant degeneration are sometimes reported, especially in case of with the patient as multiple osteochondromas. But its malignant changes or malignant degeneration are less common in case of hereditary osteochondroma. This osteochondroma rarely develop in the joint. There is a special disease called Tumors disease, also known as dysplasia epiphysealis hemimelica, and it has a special type of intra-articular epiphyseal osteochondroma. Jointly भित्र नै osteochondroma develop हुन्छ यसमा चाहिँ Tumors disease मा. Most of the osteochondromas are asymptomatic, and sometimes they may be discovered incidentally. They may sometimes present mechanical symptoms with pain, and very less likely associated with pathological fractures. Neuropathies due to compression of the nerve by tumors have also been reported. Hereditary multiple exostoses. हैन osteochondromaलाई पनि आफू पनि भन्छ, आफू नाममा exostoses पनि भन्छ है. It's an autosomal dominant disease. It is associated with multiple osteochondromas in bone. Arises from the osteochondral ossification. The patient presents with skeletal deformities and short stature, and this disease is associated with the defect in EXT1 and EXT2 gene. Diagnosis, generally X-ray is enough for the diagnosis, but in X the cap is not visible. Okay, it has the eccentric bony outgrowth from the metaphyseal region of the long bone composed of cortical and medullary portion. Duita bone both cortical and medullary portions are present within the osteochondromas. The osteochondroma are continuous with that of the underlying bone, and the cap is not visible because it's made of cartilage, and this test is usually sufficient for the diagnosis. This is the osteochondroma. Small lesions which doesn't cause any symptoms, just observation is enough. Whereas if the patient has some cosmetic problem, or if there is if it is associated with joint dysfunction or joint contraction, if it is associated with the fracture or engagement of any nerve, vessels, or tendon, or if it is associated with the malignant changes, then we go for surgery. Generally, surgery is done by complete excision of osteochondroma, including the perichondrium. All the cartilage as well as the periosteum around the base of the lesions are excised, and there is less recurrence if there is incomplete removal of the base of the lesion as well as the cartilage, then there may be chance of recurrence. Okay, this much for today. And we have more 30 more lectures in the coming lecture, 30 more slides, and if you have any questions you may ask. Yeah, we still have 30 more minutes, so I know that, but this topic is very confusing. Okay, I think we better stop and discuss in any portion if you are confused, if you have any kind of confusion. Especially your topic भनेको तिमीलाई एकदम स्पष्ट भन्दाखेरि यो टपिकहरु भनेको एमसीक्यू लाई एकदम हिट टपिक हो र लङ क्वेशन पनि यसबाट पर्छ बेनाइनमा भन्दा पनि स्पेशली माइग्रेनमा पर्छ है सर्ट क्वेशनको लागि चाहिँ एकदमै एमसीक्यू लाई एकदमै हिट च्याप्टर हो है ओके सो त्यही अनुसारको तिमीहरुको प्रिपरेसन हुनु पर्यो जुन कुरा मैले चाहिँ दुई तीन चोटी रिपिट गरेर भनेको छु त्यो कुराहरु तिमीलाई आउन सक्छ स्पेशली आई अल्सो फेस दैट ड्युरिङ माइ पीजी लेभल एक्जामिनेसनमा चाहिँ तिमीहरुको प्रिपरेसन भनेको पीजी लेभलको हो एकैचोटी पीजी लेभलमा चाहिँ तिमीलाई पीजी लेभल कसरी एपियर हुनुपर्छ त्यो कुरालाई चाहिँ ध्यानमा राखेर मैले यो डिजाइन गरेको छु कोर्स डिजाइन गरेको छु तिमीहरुको महेश्वरीमा पनि इनफ चाहिँ कुराहरु है कति कुराहरु चाहिँ जुन सोध्छ जाँचको एक्जामिनेसन सोध्छ तिमीहरु एमबीबीएस मात्र गरेर हुँदैन पीजी पनि गर्नुपर्ने हुन्छ त्यो अनुसारको तिमीहरुलाई चाहिँ फिडब्याकहरु पनि मैले दिनुपर्ने हुन्छ र कुनै कुरामा त्यस्तो कन्फ्युजन छ भने इफ यु हेभ एनी कन्फ्युजन यु क्यान आस्क द ट्युमर्स उस्तै नाम हुन्छ झुकिन सक्छ मान्छेहरु कसरी याद गर्ने हैन कुनै पनि ट्युमरहरुको बारेमा तिमीलाई सर्ट नोट्सहरु लेख्नु पर्यो भने हैन स्पेशली यो ट्युमर के ओरिजिनको ट्युमर हो फर्स्टमा हैन कुन एज ग्रुपमा हुन्छ हैन कुन एज ग्रुपमा हुन्छ बोनको कुन पार्टमा हुन्छ मेटाफाइसिस डायाफाइसिस र इपिफाइसिस कुनमा हुन्छ हैन त्यो कुराहरु याद गर्नु पर्यो अनि त्यसपछि यसको चाहिँ क्लिनिकल प्रेजेन्टेसन स्पेशली कुनैको चाहिँ स्पेशल हिस्टोलोजिकल फिचर्सहरु हुन्छ सो कुनै कसैले यो म्यालिग्नेन्टमा गर्छ कि छैन जस्तै यो ओस्टियोकोन्ड्रोमा म्यालिग्नेन्ट भएको छ कि छैन भने कसरी थाहा पाउँछ त्यो कुराहरु पनि मैले यहाँ तिमीलाई यो धेरै डिटेल हुन्छ मास्टर्स लेभलको हुन्छ भने मैले तिमीलाई उल्लेख गरेँ त्यसले तिमीलाई जान्न इच्छा छ भने when the incontrol cap is greater than 2.5 centimeter हैन greater than 2.5 centimeter the cap भएको छ when it is associated when the lesion is increasing in size or increasing भएको छ associated with the pain then malignancy is suspected especially CT मा चाहिँ क्याप को साइज ठुलो देखियो भने चाहिँ malignancy सस्पेक्ट गर्न पर्ने हुन्छ त्यो पनि one of the most important र mostly talked about topics र mostly asked topic in examination point of view osteochondroma in case of osteochondroma है एक्जोस्टोसिस है मल्टिपल हेरिडिटरी एक्जोस्टोसिस जुन इपोनिम्सहरु छ सबै कुराहरु याद गर है इपोनिम्सहरु स्पेशली यो तिमीलाई यसमा धेरै लङ क्वेशनहरु चाहिँ सोध्दा जस्तो लाग्दैन यो बेनाइन बोन टिमरमा तिमीलाई इम्पोर्टेन्ट एउटा जायन्ट सेल टिमर जीसीटी हो है जीसीटी हो जीसीटी को बारेमा म भोलि तिमीलाई राम्रोसँग डिटेलमा गर्छु त्यसपछि अझै क्लास छ भने म तिमीलाई अझै भोलि जीसीटी लाई फोकस हुनको लागि म तिमीलाई एउटा अझै एउटा यो चाहिँ कोन्ड्रोब्लास्टोमा पढाइरहनु कोन्ड्रोब्लास्टोमा भोलि नै गरौँ धेरै छैन 30 वटा छ भ्याइन्छ है धेरै एकैचोटि पढ्नु हुँदैन है ठिकै पढ्ने अहिले यो पढ अनि त्यसपछि तिमीले आफ्नो मोइसन टेक्स्ट बुक पनि हेर त्यति भए इनफ हुन्छ तिमीलाई so if you are interested then you can look at Campbell also Campbell मा पनि पढ्न सक्छौ okay any questions हैन म मैले चाहिँ बेनाइन टपिक कभर गर्छु बेनाइन बोन टिमर्सहरु कभर गर्छु भने ज्योति सरले चाहिँ म्यारिनेट पढाउनुहुन्छ है ज्योति सरले चाहिँ अनि टिमर क्लासिफिकेशन्सहरु तिमीलाई डब्ल्युएचओ क्लासिफिकेसन सोध्न सक्छ अब कहिलेकाहीँ कुनै टिचरहरुले चाहिँ एनिकिनहरु पनि सोध्न सक्छ अब नयाँ अब डिमान्डहरु हुन्छ एनिकिन क्लासिफिकेसन एनिकिन क्लासिफिकेसन इज बेनाइनमा पनि छ म्यारिनेट पनि छ है तिमीलाई इन्ट्रेस्ट लाग्यो भने पढ्न सक्छ ज्योति सरले नै म्यारिनेटको ज्योति सरले नै पढाउनुहुन्छ होला है ल आजको लागि यति नै बरु रिभिजन गर के त्यही कुराहरु रिभिजन गर धेरै पढ्नु नै हुँदैन थोरै पढ्ने तर जे कुरा छ त्यो रिटेन गर्ने तर राम्रो इफेक्टिभ रिडिङ चाहिन्छ है ल दिस मच फर टुडे